Historically, catheter-associated urinary tract infections, or CAUTIs, account for about a third of hospital-acquired infections. However, with increasing recognition of bladder and catheter colonization, as well as recent surveillance definition changes, the number of CAUTIs relative to other HAIs has been decreasing. The new guidelines by IDSA, which is the Infectious Disease Society of America, as well as the American College of Critical Care Medicine, recommend against treating positive cultures in a catheterized patient unless you've ruled out other sources of fever. So focusing on appropriate culturing in catheterized patients is very important, especially towards supporting antimicrobial stewardship efforts. The goal of our project was really to develop an evidence-based urine culture algorithm to help support our CAUTI prevention efforts, as well as our antimicrobial stewardship efforts. This project was carried out at Yale-New Haven Hospital, which is a 1,500-bed hospital in New Haven, Connecticut. We have a catheter-associated urinary tract infection, or CAUTI, performance improvement team, which is a multidisciplinary team comprising of urologists, infectious disease physicians, pharmacists, nurses, infection preventionists, and many other providers that come together and developed a urine culture algorithm, which was based on the IDSA guidelines. The algorithm basically recommends directed evaluation of fever in a catheterized patient prior to getting a urine culture. We rolled out this algorithm stepwise. It was developed in October. There was a large-scale education project that initiated in November of 2017, and the algorithm was rolled out house-wide in December of 2017. The electronic medical record was optimized to include this algorithm in February of 2018. However, we started to see a lot of the impact of this algorithm very early on. Our goal was to study the impact of this algorithm by looking at the rates of our urine cultures, the rates of our catheter-associated UTIs, as well as our central line-associated bloodstream infections before and after algorithm implementation. When we compared these rates, we found that our urine culture orders dropped drastically by 30% before and after algorithm implementation. In addition to this, we also found that our catheter-associated urinary tract infection rates also dropped significantly by 30% prior to and after algorithm implementation. Prior to algorithm implementation, our CAUTI rate was 1.3 per 1,000 catheter days, and after algorithm implementation, it dropped to 0.9 per 1,000 catheter days. We did not see an incidental increase in our central line-associated bloodstream infection rates or an increase in our blood culture orders as a result of this algorithm. So we found that with thoughtful culturing, we did see that people focused a lot on directed evaluation of fever in our catheterized patients. We had implemented staff education not just about appropriate culturing, but also about appropriate catheter utilization. So we decreased our utilization rates as well. And with this multidisciplinary effort, we were able to decrease our CAUTI rates. So our next steps are to go ahead with an interrupted time series analysis to see the impact of this algorithm over an extended period of time, and also expand this to our system hospitals in the community for better generalizability of our results.